7. Go ahead and turn your page, sorry, to page 420. And we're gonna start with a digital rectal exam. So now today,
Brianna and Audrey.
can I have Brianna and Audrey? Mr. Joey in the back. So we'll start with digital rectal exam. We will cover a couple of female at the end, which is cystoscopy and rectoscopy. That shouldn't be too bad. But let's just cover male as it can go by quite quickly. So we'll cover a few diagnostic procedures. And then we're gonna cover a couple of disorders, which is benign prostatic hyperplasia and erectile dysfunction. Okay, first one. Let's go over digital rectal exam. Okay, left side, page 420. So digital, right? A digit, a finger. Okay, is done in an office or clinic in which a provider can examine the client's prostate, rectum, pelvis, and lower abdomen to identify any unexpected findings, such as lesions or masses. The ACS recommends that a discussion for prostate cancer screening start at the following interval. So when does the screening begin? Age 40 for clients who are at greater risk. That means that they have more than one first-degree relative, a parent or sibling, who has had prostate cancer. Age 45 for high-risk clients who are African American or first-degree relative. Age 50 for clients who are at average risk with a life expectancy of more than 10 years. After this discussion between the client and the provider occurs, the client can decide to provide a consent, screening, and testing for PSA and digital rectal exam. The client is positioned leaning over the examination table or sideline fetal position. The provider inserts their glove and lubricated finger in the client's anus and can palpate the rectum, anus, or prostate. The provider identifies any unexpected findings. The client may require further testing, like an ultrasound or a biopsy, to determine the exact findings. The client, what you gotta teach them is, they may feel the urge to urinate during the exam. So the key points here for this one are position. Leaned over table. Or sideline fetal. Glove and lubricated finger is inserted, and you'll palpate anus, rectum, prostate. Okay. Patient teaching may feel the urge to urinate. Now, we're going to go over a couple of blood tests, and I want to point out something about it. Let's go to page 425 and 424. The two tests that we're going to look over are PSA, which stands for prostate specific antigen, and EPCA. both found on this table. Now let's start with PSA. Page 425. You'll see the indication. Measures the amount of protein produced by the prostate. Now look at the second sentence. Measured before the digital rectal exam. Before DRE. This is because stimulation of the prostate can cause the PSA level to be elevated. Okay? So you will take their blood levels before the digital rectal exam. That's a key point. Okay, tests can detect prostate cancer and stage cancer of the prostate. The ACS recommends against having routine screening if the client is at average risk. If the client desires testing and the initial PSA is less than 2.5, they may only need to be retested every 2 years. Screening should be done yearly for men whose PSA is 2.5 or higher. Clients without symptoms of the prostate cancer and less than 10-year life expectancy should not be offered testing, since they are not likely to benefit. Testing since they are not likely to benefit because of the prostate cancer grows slowly. After a decision about testing has been made, the discussion of risks and benefits should be repeated as new information becomes available. Further discussions are also needed to consider. Now I want you to see more so the levels, expected reference ranges. You see less than 2.5, you are good. Okay, right? 2.5 or which is 2.6 or higher, okay, slightly or more than 10, moderately elevated. These people will continue to be with more diagnostic procedures to see if anything is wrong. So more than 2.5 and additional testing may be needed. Now the book says here that this can also be used for prostate cancer and like prostate staging, like cancer, things like that. And while that may be true, the more important thing is that from a PSA, look carefully at your question. Because a prostate-specific antigen can be caused by a variety of things, such as BPH, infection, even if not infection, just inflammation, stimulation, such as palpating it. Okay? All of these can raise the PSA level. Okay? Realistically, you're concerned when this level is higher than 4. That would bring concern. Less than 2.5, you shouldn't be worried. Benign prostatic hyperplasia, infection, cancer, inflammation, palpation, all of these can affect the level. So it's not specific to either one of these. Okay? Now let's look at EPCA, early prostate cancer antigen. EPCA, also known as EPCA, and they put a 2 at the end. On the page of 424 at the bottom. Determines the amount of protein in blood that is only produced by unexpected prostate cells to determine if biopsy is needed. EPCA2 is highly sensitive in detecting prostate cancer. Some providers are using this test in place of a biopsy. Okay? Less than 30 is normal. More than 30, prostate cancer. Okay? EPCA2. Now this is very accurate as this is specific to cancer. EPCA2 is only produced by mutated cells, while PSA can be produced by, again, infection, stimulation, BPH. By which one? EPCA2 can only be produced by cancerous cells, by mutated cells. Yes.
You know, it's one thing
some providers will just take this as a diagnosis. However, majority on top of this, with an ultrasound or feeling, can be more accurate, as you can see that there's a mass or growth. So the key thing that you should understand here, and to serve you as a purpose for your test, is should PSA be indicative of cancer?
No.
Possibly, right? But we don't know. It could be inflammation, infection, BPH. It's not specific. So if you're asked to which test will show the potential, right, the more probability of cancer, EPCA2. Now, if EPCA2 is not here, and you're looking at other markers like WBC, platelets, and this, and PSA, obviously PSA is the best indicator after that of potential for cancer. Does that make sense? Yes.
So for the PSA, like if it was above 4, would they then order it, or do they go over?
Depends. So if you're already gonna come in to be tested for these things, they'll probably just order both. And in some cases, if they only order the PSA and that brings alarm to it, then you can then test for any PCA. Just because some tests are more expensive. So unless there's a reason to do them, they don't. Okay? Yeah.
I thought for the PSA, the levels increase by age.
It will. That's why, again, less than 2.5 is usually okay for those under 40. As they become over 40, the level will rise, but you won't be concerned until after 4.
Sorry, question. So you wouldn't use the biopsy then to detect it then because you use the EPCA, right?
Right.
Okay.
But, according to the book, you would get a biopsy to confirm.
Because on the book I have, the other one, it says EPCA is being used to test in place of a biopsy because it's sensitive to testing.
Yeah, so I'd say read into your question. In real life, can both be used? Yes. As for your question, again, see what it's deliberately asking. Good. I can't or don't know how or what will be phrased on your proctors, but that's why I try to give you the best idea of the facts of how they're trying to verbalize it here themselves. Does that make sense? So no, they could attribute to many or EPCA. Should you have both present on there, but it's asking about cancer, it's the EPCA. Make sense? All right. So we know the levels. Please know your levels, okay? And then know the reasoning behind them. Good so far? Okay. Go to page 427. All right. Look at the right side of page 427. Transrectal ultrasound and prostate biopsy. So just like what it sounds like, a probe will be inserted in the rectum and an ultrasound will be taken of the prostate and possibly a biopsy. This to again detect and or try to confirm prostate cancer. Now what I want you to know is look at the potential contraindications at the bottom. 1, that on anticoagulants, these medications may need to be stopped before the procedure. But more importantly is you always check if they have a latex allergy because the probe is covered with the latex cover. So you have to check if they have a latex allergy. Everybody heard that? Everybody got that? Okay. hold your anticoagulants. Check for latex allergy, as this cannot be given if they do. Okay, client education, what will they do to prepare? Take an enema 1 hour prior to the procedure. Instruct the client about breathing and relaxation techniques during the procedure. Inform the client if biopsy was performed, there could be mild discomfort and slight hematuria, urine or blood light red, right, urine, and scant rectal bleeding for a few days. Inform the client to take a mild analgesic for the pain. Okay. Post-procedure, refrain from strenuous activity like heavy lifting for 24 hours after the biopsy. Okay. Pre, make sure that they have informed consent for this, for the biopsy, right? Post, no heavy lifting. Give them wipes to clean perianal, right? Check for latex allergy in the pre. Remember, for diagnostic procedures, if you look at the questions, you know, they try to ask you usually that, right? A client is being prepared for X procedure, what should you check for first, or what should you verify, right? Or what, like, again, then they're asking for pre-procedure, what should be in place? Whether it's patient teaching, informed consent, or checking for any contraindications, types of allergies, medications that they're taking. This one's pretty specific, right? The latex allergy, informed consent is universal for risky procedures. And then there's another one, right? For any type of graphy, right? Whenever you see, right, angiography, anything to do with an angio where they're injecting dye, what do we check for? Iodine shellfish allergy, and what's the medication that you check for? Metformin. So the iodine shellfish allergy, I think everybody's kind of getting a hold of, that's universal, okay? Whether it's a cerebral, angiography, abdominal, it doesn't matter where. They're gonna use dye, you check for the iodine shellfish allergy. And you stop metformin for a day or two before and a day or two after, or else this can impair kidney function, okay? So those are the two things to make sure you check for. What's the last thing you check for? There's three. So iodine shellfish allergy, metformin is a medication. Their kidney function, because they will excrete the contrast through there. The kidney. Okay? That's universal for all types of angiographies. You good? All right. Next chapter, 59. Go ahead and go to page 447.